Our lungs are covered by two layers of pleura, the inner visceral pleura and the outer parietal pleura. Sandwiched between these layers is the pleural space, which normally contains about 10 milliliters of fluid that provides a bit of lubrication so that the lungs can smoothly expand within the chest cavity without encountering too much friction. Too much fluid in that space results in a pleural effusion, which can actually hinder lung expansion. Now, pleural effusions can be broadly classified into transudative and exudative effusions. Transudative effusions are often caused by systemic diseases and result from either an increase in the intravascular hydrostatic pressure, such as in congestive heart failure, or as a result of a decrease in the intravascular oncotic pressure due to a decrease in serum albumin, like in liver cirrhosis, nephrotic syndrome, or malnutrition. Exudative effusions, on the other hand, are usually due to local diseases that may cause inflammation, resulting in increased capillary permeability. These include infections like pneumonia or tuberculosis, primary lung or metastatic malignancy, autoimmune diseases like systemic lupus erythematosus or rheumatoid arthritis, or pancreatitis. One more specific type of effusion is chylothorax, and it results from impaired lymphatic drainage of the pleura, which can happen after accidental damage during surgery, trauma, or cancer invasion. Interestingly, pulmonary embolism can cause both transudative and exudative effusions. The transudative component is thought to occur during obstruction of the pulmonary circulation, causing an increased hydrostatic pressure in that area. The exudative component occurs due to release of vasoactive mediators from the platelet-rich clots, which increase capillary permeability. Now, regardless of the cause, the symptoms of a pleural effusion include progressively worsening shortness of breath due to limited expansion of the lungs, and pleuritic chest pain, which is a sharp pain that worsens with inspiration due to irritation of the somatically innervated parietal pleura. However, like in the style of Sherlock Holmes, you should look for associated symptoms that may clue you to identifying the potential etiology. For example, fever, chills, and a productive cough may indicate pneumonia. Unintentional weight loss and loss of appetite may indicate a malignancy. Night sweats, travel to an endemic area, and hemoptysis can indicate tuberculosis. Orthopnea and paroxysmal nocturnal dyspnea can indicate congestive heart failure. History of occupational exposure to asbestos may point towards mesothelioma. Joint pain or a rash can indicate autoimmune disease, and so on. Normally, on physical exam, there are diminished breath sounds on auscultation, and dullness when percussing the affected area. Additional physical exam signs that may help narrow the differential diagnosis include peripheral edema, crackles, and an S3 heart sound, which may indicate heart failure. Stigmata of chronic liver disease, like jaundice and dilated umbilical veins, may indicate cirrhosis. A joint effusion, along with a pleural effusion, may indicate an autoimmune disease. Keep in mind, if you're effusing in two, think autoimmune. Alright, now to actually see an effusion, a chest x-ray is done. Uniquely, it's obtained both while the individual is upright and laying down on their side, called the lateral decubitus position. Now, the goal of a chest x-ray is threefold. Diagnose the presence of a pleural effusion, then determine if it's freely flowing in the pleural space, which may clue towards a transudative effusion, or if it's stuck and loculated, which may indicate an exudative effusion, and finally, determine if we can obtain a sample of the pleural fluid. When the individual is upright, it takes at least 250 milliliters of fluid to see a pleural effusion. Now, normally the costophrenic angle, which is the angle between the pleura covering the ribs and the pleura covering the diaphragm, is sharp and well demarcated. In a pleural effusion, however, this angle is obliterated by the radiopaque or white fluid. Larger effusions can also obscure the diaphragmatic contour and heart borders, form an air fluid level similar to a half-filled cup of water, or they can form a concave upper surface that looks like a moon crescent and is called the meniscus sign, because meniscus is Greek for crescent. Also, massive effusions can push the entire mediastinum to the opposite side, which can cause the trachea to shift from the midline. Now, since transudative effusions are often caused by a systemic disease, there are usually bilateral effusions of similar size. In contrast, exudative effusions are usually caused by localized disease, and therefore are usually unilateral, or of different sizes. But there are plenty of exceptions to this rule. For example, early on in congestive heart failure, there may only be an effusion on one side, and conversely, a large pneumonia might lead to bilateral effusions. Alright, now on the other hand, lateral decubitus films can detect effusions that are as little as 50 milliliters, and also help tell us if the effusion is free-flowing, which is where the fluid layers on top of the chest wall, or loculated, in which the fluid doesn't layer. An alternative to chest X-ray is a bedside ultrasound, and that can help determine the amount and nature of the effusion. A homogeneous black effusion means that it's free-flowing and probably transudative, whereas a heterogeneous effusion with white septations indicates that it's loculated and probably exudative. Now, on lateral decubitus chest X-ray, we look at the distance between the chest wall and the top of the fluid level. Kind of like measuring the depth of an ocean, the chest wall being the seabed and the fluid level being the surface of the sea. If this distance is at least 1 centimeter, then there's enough fluid to proceed to the next step, a diagnostic thoracentesis, which is inserting a thin needle through the chest wall to obtain a sample of the effusion. This is different from a therapeutic thoracentesis, which is aspirating at least 1 liter of pleural fluid, providing symptomatic relief from massive effusions causing shortness of breath. The bedside ultrasound can be used to visually guide the needle through the chest wall, which prevents damage to nearby structures like the liver. Also, it's crucial to insert the needle above the rib to avoid damaging the intercostal vein, artery, and nerve, the van that runs at the inferior edge of the rib. Now, when performing a thoracentesis, there's a small risk of introducing air into the pleural space, causing a pneumothorax. And for small effusions, where the distance is less than 1 centimeter, the risk of a pneumothorax is even greater. Additionally, the individual is likely asymptomatic, and therefore can simply be observed. So that's why a thoracentesis isn't typically done for very small effusions. Another exception to performing a diagnostic thoracentesis is if an individual with congestive heart failure has recurrent chronic effusions. Then you don't need a sample, since the diagnosis is pretty straightforward. In that situation, diuretics are typically used as a first-line approach. A therapeutic thoracentesis may also be performed if the effusion is massive. Now, if the effusion doesn't improve, then there must be another problem, and a diagnostic thoracentesis may be needed. Pleural fluid can appear serous, which is to say clear, or it can be bloody and purulent. Serous fluid is often seen in transudative effusions, whereas bloody fluid can indicate malignancy, a pulmonary embolism, or trauma, and purulent fluid indicates an infection. Milky white fluid indicates a chylothorax, and it appears milky because lymph contains large amounts of triglycerides and chylomicrons. Now, to definitively determine if the fluid is transudative or exudative, we can use the Leitz criteria. Pleural fluid is considered exudative if any one of the following are met. A pleural fluid total protein to serum total protein ratio more than 0.5, a pleural lactate dehydrogenase, or LDH, to serum LDH ratio more than 0.6, or a pleural fluid LDH more than 2/3 of the upper limit of normal serum LDH. It's very important that you don't miss an exudative effusion, so the criteria are designed to be overly sensitive. Now, if none of the Lights criteria apply, it's a transutative effusion. In that case, it's okay to treat the underlying cause and no further tests are needed. However, if the pleural fluid is exudative, then more testing is needed. If a malignancy is suspected, then pleural fluid cytology should be done to look for malignant cells. In a bacterial pneumonia, the pleural fluid white blood cell count can show a predominance of neutrophils. Now, effusions secondary to pneumonia can be simple, also called parapneumonic effusions, or complicated, also called empyema. A parapneumonic effusion literally translates to an effusion around an infection. So, it's an inflammatory reaction of the cells lining the pleura in response to the nearby infection. Consequently, parapneumonic effusions are often sterile, meaning a gram stain in culture would be negative. Parapneumonic effusions improve as the pneumonia resolves. On the other hand, empyemas occur when bacteria have actually invaded into the pleural space. Empyemas are often loculated and full of bacteria, pus, and adhesions. A positive gram stain in culture, a pleural fluid pH of less than 7.2, or a pleural glucose level below 60 milligrams per deciliter can also indicate an empyema, but they're not specific. Alright, now empyemas typically require surgical drainage with a thoracostomy or chest tube in addition to antibiotics. If a cell count shows that the lymphocytes are predominant, then tuberculosis should be considered. Supporting features of tuberculosis include a high level of adenosine deaminase and a positive polymerase chain reaction, or PCR test, for Mycobacterium tuberculosis. Typically, the acid-fast stain and culture of the pleural fluid are rarely positive. So, the most sensitive and specific test for pleural tuberculosis is a pleural biopsy, which is actually taking a chunk of the cells lining the pleura and sending it off to the pathology lab to look at the cells under a microscope. A pleural fluid amylase to serum amylase ratio more than 1 may indicate pancreatitis. However, because amylase can also come from the salivary glands, a rupture of the esophagus can also result in an elevated pleural to serum amylase ratio. Finally, a pleural triglyceride level more than 110 milligrams per deciliter indicates a chylothorax. If an individual has recurrent pleural effusions due to a malignancy like lung cancer or metastatic cancer, then a palliative procedure called a pleurodesis can be performed. Pleurodesis means obliterating the pleural space, so that fluid can no longer accumulate. This procedure can be performed by introducing chemicals like talc, silver nitrate, or the antibiotic doxycycline, all of which induce an inflammatory response that eventually results in fibrosis, effectively sticking the visceral and parietal pleura together. Another option is mechanical pleurodesis, in which a surgeon enters the lung using video-assisted thoracoscopic surgery, or VATS. Once in the pleural space, the surgeon repeatedly rubs an abrasive tool against the pleura, inducing fibrosis. Alright, as a quick recap. Pleural effusions can be transutative, which are often caused by systemic diseases, or exudative, which are often caused by local inflammatory diseases. The first step in evaluating a pleural effusion is imaging with an upright and lateral decubitus chest X-ray, or a bedside ultrasound, to determine if the effusion is free-flowing or loculated. After that, the effusion is sampled by doing a thoracentesis, and the Lights criteria are applied to determine if it's transutative or exudative. An effusion is exudative if any one of the following apply: a pleural fluid total protein to serum total protein ratio more than 0.5, a pleural lactate dehydrogenase, or LDH, to serum LDH ratio more than 0.6, or a pleural fluid LDH more than 2/3 of the upper limit of normal serum LDH. If transutative, then the underlying cause is treated. If exudative, additional tests are done on the pleural fluid depending on the suspected cause. The pleura is the blanket that covers our lungs, and it's made of two layers: the inner visceral pleura and the outer parietal pleura. In between those two layers is a space. If air gets in that space, it's called a pneumothorax. Pneumothoraces can be classified into two broad categories: spontaneous or traumatic. Spontaneous pneumothorax is further subclassified into primary and secondary. A primary spontaneous pneumothorax occurs without a triggering event in an otherwise normal lung. Most commonly, an individual at risk of primary spontaneous pneumothorax is a tall, thin, young male presenting with symptoms that started at rest.
Hey.
This is because there are more mechanical shear forces at the apex of the lung that can make the pleura rupture, especially after, for some reason, holding their breath, like during diving, or inhaling and holding a recreational drug or medication in their lungs. Another risk factor for primary pneumothorax is smoking cigarettes and systemic syndromes like Marfan disease. Then, there's a secondary pneumothorax, that is, a spontaneous pneumothorax that occurs in a lung with pre-existing lung disease, like chronic obstructive pulmonary disease, or COPD, asthma, interstitial lung disease, tuberculosis, cystic fibrosis, or lung cancer. In COPD, destruction of the alveolar sacs leads to formation of large alveolar blebs, which are small balloons that can eventually rupture, leaking air into the pleural space. Traumatic pneumothorax occurs secondary to injury of the pleura after blunt or penetrating trauma to the chest, like a stab wound, or as a complication of a procedure, such as a lung biopsy, thoracentesis, central line insertion, or mechanical ventilation. Now, any pneumothorax, regardless of how it forms, can potentially become a tension pneumothorax, but it most often happens in a traumatic pneumothorax, which most often occurs due to a punctured lung. Causes can include a broken rib puncturing through the pleural space, or even after CPR. Tension pneumothorax is when the injured pleura forms a one-way valve allowing air to go in but not go out. This means that with every breath, the pneumothorax gets bigger and bigger. Now, in cases of a tension pneumothorax, it can compress the right atrium of the heart and the vena cava, decreasing venous return. This results in decreased cardiac output manifesting as hypotension, altered mental status, and an elevation of the jugular venous pressure, and this is typical of obstructive shock. In fact, because of the external pressure, sometimes the right ventricle can't move into the pericardial space, so the extra volume pushes the intraventricular septum toward the left. This leads to a reduction in left ventricular diastolic volume, a lower stroke volume, and a drop in systolic blood pressure during inspiration. A decrease in the systolic pressure of greater than 10 millimeters of mercury is called pulsus paradoxus. Additionally, in a tension pneumothorax, the mediastinum and the trachea may be shifted to the contralateral side. In terms of symptoms, a small pneumothorax may cause no symptoms, but typically a pneumothorax causes a sudden onset of shortness of breath and unilateral pleuritic chest pain, which is a sharp, knife-like pain that worsens with inspiration due to irritation of the parietal pleura by the expanding lung. It also typically causes tachycardia, tachypnea, or hypoxemia. Examination of the chest reveals decreased air entry or absent breath sounds on auscultation, and hyperresonance on percussion of the affected area. The diagnosis of a pneumothorax is confirmed by a chest X-ray, which shows a visible white visceral pleural line that's separated from the parietal pleura by pitch black gas. It's important to distinguish the pleural line from the border of the scapula on a chest X-ray. Additionally, the normal pulmonary vessel markings that branch from the hilum of the lung suddenly disappear beyond that visceral line. This is why we obtain these films during expiration, because when the individual breathes out air from their lungs, the lungs will shrink a bit, making it easier to detect even small pneumothoraces. Additional findings include flattening of the normally convex hemodiaphragm and deepening of the costophrenic angle, which is the angle between the pleura covering the ribs and the pleura covering the diaphragm. In secondary spontaneous pneumothorax, other findings of underlying lung disease will be present, such as hyperinflation in COPD. Now, in a non-tension pneumothorax, you may also see mediastinal shift toward the side of the pneumothorax, while in a tension pneumothorax, mediastinal shift will be away from the pneumothorax. Now, initially, all patients with a spontaneous pneumothorax are put on supplemental oxygen, even if they're not hypoxemic. The idea behind this is that the air in both the alveoli and the pneumothorax is mostly composed of nitrogen, about 78% nitrogen. So, by giving oxygen, we make the alveolar air mostly contain oxygen with very little nitrogen. This increases the nitrogen gradient between the pleural space and alveoli. So, nitrogen in the pneumothorax will just diffuse from the pleural space to the alveoli, allowing the individual to essentially breathe most of the air in the pneumothorax right out. Alright, now the subsequent steps of management depend on the size of the pneumothorax on chest x-ray, and the stability of the symptoms. Definition of stability must include a respiratory rate lower than 24 breaths per minute, a heart rate between 60 and 120 beats per minute, a normal blood pressure with cutoff values that are not established, room air oxygen saturation higher than 90%, and have the ability to speak in whole sentences. If any of these characteristics is not met, the individual is considered unstable. Starting off from primary pneumothorax, it is considered small when it's less than 3 centimeters distance between the pleural line and the chest wall at the level of the apex, or less than 2 centimeters between the pleural line and the hilum. Stable individuals with a small primary pneumothorax can be safely discharged, with a follow-up x-ray 1 to 2 weeks later to make sure the pneumothorax is gone. On the other hand, if the individual is stable but the pneumothorax is large, then a pleural aspiration with needle thoracentesis is performed. This involves inserting a small bore needle or catheter into the chest to aspirate the air in the pleural space. Now, it's important to insert the catheter above the rib to avoid damage to the intercostal vein, artery, and nerve, or the vein running below the rib. If pleural aspiration fails, then a thoracostomy or chest tube is inserted. Finally, all unstable individuals must be immediately treated with needle thoracostomy, which uses a larger bore needle than needle thoracentesis, allowing more rapid decompression of the chest cavity. Alright, moving on to secondary spontaneous pneumothorax. Similar to primary spontaneous pneumothorax, supplemental oxygen is given to all patients, and subsequent management depends on the size of the pneumothorax and the stability of the symptoms. But the difference is that the thresholds are lower because this individual already has underlying lung disease. If the pneumothorax is small, so less than 2 centimeters distance between the pleural line and the chest wall at the level of the apex, and the patient is stable and completely asymptomatic, or with minimal symptoms, then the patient is usually admitted for 24 hours of observation. Now, if the individual has a small pneumothorax and is stable, but presents with significant symptoms, if they have a large pneumothorax, or if they're unstable, then pleural aspiration with needle thoracoscopy is done. Finally, it's notable that both primary and secondary spontaneous pneumothorax tend to recur, but because of the underlying lung disease, secondary pneumothorax recurs more often. Therefore, if an individual has their second primary or first secondary spontaneous pneumothorax, or has a spontaneous pneumothorax that isn't disappearing following chest tube insertion, then surgical intervention can be considered, since the chances of recurrence progressively increase with each new pneumothorax. It's also important to always surgically intervene in individuals working in a high-risk occupation that subjugates them to large changes in atmospheric pressure, such as a scuba diver or a pilot.
We hope you enjoyed the flight, and have a nice day.
The main surgical option is pleurodesis, which is obliterating the pleural space so that air can no longer accumulate. This procedure can be performed by introducing chemicals like talc, silver nitrate, or the antibiotic doxycycline through a chest tube. These chemicals induce an inflammatory response that eventually results in fibrosis, effectively sticking the visceral and parietal pleura together. Another option is mechanical pleurodesis, in which a surgeon enters the lung using video-assisted thoracoscopic surgery, or VATS. Once in the pleural space, the surgeon repeatedly rubs an abrasive tool against the pleura, inducing fibrosis. Now, attention pneumothorax is a clinical diagnosis, meaning that if it's suspected based on symptoms and presentation, the diagnosis doesn't need to be confirmed with a chest X-ray. Rather, it's a medical emergency that must be immediately treated with needle thoracostomy, by inserting a needle in the second or third intercostal space at the midclavicular line, decompressing the pneumothorax. To confirm decompression, the individual's breathing will improve, and you might even hear the air escaping. It's usually pretty dramatic. Following decompression, a chest tube is inserted in the fourth or fifth intercostal space along the anterior axillary line. Now that the patient is properly breathing, you can breathe too, and get that chest X-ray. It's also important to address the tension pneumothorax before intubation, and that's because mechanical ventilation can worsen a tension pneumothorax. That's because you're supplying air that's under positive pressure, basically adding fuel to the fire. Alright, as a quick recap. Pneumothoraces can be broadly classified into spontaneous and traumatic pneumothorax. Individuals present with sudden onset shortness of breath and pleuritic chest pain. The diagnosis is confirmed with an expiratory chest X-ray. The management depends on the size of the pneumothorax and the stability of the symptoms, ranging from simple observation to pleural drainage and chest tube insertion. Due to their recurrence, chemical or mechanical pleurodesis can be done, effectively obliterating the pleural space. Finally, a tension pneumothorax often occurs in the setting of chest trauma and can potentially result in cardiovascular collapse. Therefore, once a tension pneumothorax is recognized by signs like elevation of the jugular venous pressure, tracheal shift, and hypotension along with the symptoms of a pneumothorax, immediate needle decompression is prioritized over obtaining a chest X-ray. Pneumothorax refers to an abnormal presence of air within the pleural space that can result in a deflated or collapsed lung. The pleural space has a parietal layer, which lines the chest wall, and a visceral layer which lines the parenchyma of the lung. Disruption of either of the pleural layers can allow air to enter the pleural space. This can occur spontaneously, usually due to rupture of anatomic lung defects called blebs and bulli, or traumatic, which might occur after a penetrating chest injury or even a medical procedure. Based on the underlying cause, pneumothorax can be classified as spontaneous pneumothorax, which is further subdivided into primary and secondary spontaneous pneumothorax, and non-spontaneous pneumothorax. Now, if you suspect pneumothorax, you should first perform an ABCDE assessment to determine if your patient is unstable or stable. If the patient is unstable, stabilize the airway, breathing, and circulation. This means that you'll need to assess the need for ventilatory support, and you might need to intubate the patient. Next, obtain IV access. provide supplemental oxygen to maintain SaO2 above 92%, and put your patient on continuous vital sign monitoring such as pulse oximetry, blood pressure, and heart rate. Next, perform a focused history and physical and get a chest x-ray as soon as possible. Your patient might report sudden chest pain and shortness of breath, while your exam will reveal an asymmetric chest and tracheal deviation away from the affected side, as well as hypotension, respiratory distress, and decreased or absent breath sounds on the affected side. Keep in mind that tension pneumothorax is a clinical diagnosis and doesn't need further testing. However, if you were to perform a chest x-ray, it would show a distinct visceral pleural edge with an absence of lung markings distally, often with a depressed hemidiaphragm ipsilateral to the collapsed lung, known as a deep sulcus sign. In severe cases, you'd see shifting of the mediastinum contralateral to the collapsed lung. Okay, listen up. Here is a clinical pearl. Since tension pneumothorax is so dangerous, it should be diagnosed based on clinical suspicion, and treatment should not be delayed, even if imaging has not been performed or results are not yet available. In fact, you'll want to perform immediate decompression with needle thoracostomy. Identify the second intercostal space where it intersects with the midclavicular line. Then insert an angiocatheter through the chest wall just above the rib. If effective, you will release the trapped air, allowing the lung to reinflate and relieve any mediastinal compression. You will later need to proceed with tube thoracostomy or placement of a chest tube connected to continuous low-pressure suction to allow full reinflation and decrease chances of recurrence. Now, let's jump back to the ABCDE assessment and take a look at stable patients. If your patient is stable, proceed with a focused history and physical examination. Your patient is likely to report sudden onset of pleuritic chest pain, or pain that gets worse with deep breathing, as well as shortness of breath. Common examination findings include tachypnea, shallow breathing, and decreased or absent breath sounds on the affected side of the chest. If these findings are present, suspect pneumothorax and order a chest x-ray. Look for a visceral pleural edge, absence of lung markings, and a deep sulcus sign, while keeping in mind a mediastinal shift is less likely to be present in a stable patient. At this point, you can be sure that the diagnosis is pneumothorax. On the other hand, if you notice findings that are inconsistent with pneumothorax, you should consider an alternative diagnosis. Now that you've diagnosed pneumothorax, the next step is to assess the underlying cause. Ask about a history of trauma to the chest wall and any recent medical procedures where inadvertent trauma may have occurred. If neither of these is present, then the pneumothorax is said to be spontaneous. If spontaneous pneumothorax occurs in the absence of trauma or known lung condition, the pneumothorax is said to be primary. Risk factors for primary spontaneous pneumothorax include young age, tall height, thin body habitus, and being a biologically male individual. Now, the first step in management of a patient with primary spontaneous pneumothorax is to assess the size of the pneumothorax. If it's small, meaning the chest x-ray reveals less than 2 centimeters between the lung edge and chest wall, next you should assess for symptom severity. As long as no symptoms are present, it may often resorb spontaneously, so you can observe your patient. However, if symptoms are present, then you'll need to perform simple needle aspiration or placement of a chest tube. On the other hand, if the pneumothorax is large, in other words, there's 2 centimeters or more in depth, then you will place a chest tube and attach it to continuous suction. Next, order a follow-up chest x-ray to evaluate the lung expansion. If there's full lung expansion, stop the suction and observe your patient for an additional 24 hours. But if the x-ray reveals no lung expansion, make sure to consult the surgical team. Now that we're done with primary spontaneous pneumothorax, let's go all the way back up to the assessment of the underlying cause. Next up are individuals that have no history of trauma but have an underlying lung condition, such as COPD or pulmonary fibrosis. In this case, the pneumothorax is classified as a secondary spontaneous pneumothorax. Here, you will place a chest tube regardless of symptoms or the size of the pneumothorax and attach the tube to continuous suction, again followed by a repeat chest x-ray to evaluate lung expansion. Just like mentioned previously, if there's full lung expansion, stop the suction and observe your patient for an additional 24 hours, but if the x-ray reveals no lung expansion, then you consult the surgical team. Finally, let's go back to the assessment of the underlying cause. And we'll take a look at patients that present with a history of trauma, such as blunt or penetrating trauma, or a history of medical intervention, such as central line placement, lung biopsy, and mechanical ventilation. In this case, you should think of non-spontaneous pneumothorax, so your next step is to assess the chest wall for penetrating injury. If there's no chest wall defect, non-spontaneous pneumothorax is classified as a closed pneumothorax. So, your next step is to assess the pneumothorax size and treat it just like you would treat the primary spontaneous pneumothorax. On the other hand, if there is a chest wall defect, then your diagnosis is open pneumothorax. So, make sure to consult the surgery team, because the chest wall may need surgical repair to allow for proper lung reinflation. Now, here's another high-yield fact. If pneumothorax occurs as a result of a medical intervention, it's called iatrogenic pneumothorax. The most common cause is an inadvertent puncture of the pleura during insertion of a central venous catheter. However, it's also known to occur during needle-based transthoracic procedures like liver biopsy and thoracentesis. They can even occur from mechanical ventilation, usually due to high expiratory pressure settings causing barotrauma. All right, as a quick recap, if you suspect pneumothorax, perform an ABCDE assessment to determine if your patient is unstable or stable. Unstable individuals typically present with tension pneumothorax and usually require immediate decompression with needle thoracostomy prior to placement of a chest tube. On the other hand, in stable individuals, use a chest x-ray to make the diagnosis. Next, review the patient's history to determine the underlying cause and type of pneumothorax. The initial step in the management of primary spontaneous pneumothorax is determine the pneumothorax size. If it's small, observe the patient as long as no symptoms are present. However, if symptoms are present, treat the pneumothorax either with simple needle aspiration or the placement of a chest tube. On the other hand, if the pneumothorax is large, place a chest tube with continuous suction. Next, order a follow-up chest x-ray to evaluate lung expansion. If the x-ray reveals full lung expansion, stop suction and observe the patient for 24 hours. But if there's no lung expansion, consult the surgical team. On the other hand, in secondary spontaneous pneumothorax, place a chest tube regardless of the size of the pneumothorax, attach the tube to continuous suction, and again order a follow-up chest x-ray to evaluate lung expansion. Finally, in non-spontaneous pneumothorax, assess the chest wall for penetrating injury. If there's no chest wall defect, the diagnosis is closed pneumothorax. So your next step is to determine the pneumothorax size and treat it just like you would treat the primary spontaneous pneumothorax. On the flip side, if you notice any chest wall defects, the diagnosis is open pneumothorax. So immediately consult the surgical team.